Thank you for being with us. Allow me to take just a few minutes to give a short introduction to both the webinar and the panelists. Yeah, the title of today's webinar is about global innovation, local solution in advancing NCDs care in Africa. Shortly, based on the WHO data, now NCDs are responsible for 40% of death in Africa. And regardless of this burden of NCDs in Africa, healthcare system across the continent remain under resources, still have a gap in resources to address these issues of NCDs. As by now, Africa is a hub of innovations. So by leveraging global advancement in healthcare technology, including policy practices, in terms of local context, there is a potential possibility to transform NCDs care's delivery from one point to another. So this webinar aims to explore how global innovations can be built to address Africa's unique healthcare system, which address the challenges and drive sustainable progress, especially in NCDs prevention, management, and care. This webinar has five objectives. The first one is to highlight the burden of NCDs in Africa. The second one is to showcase the global innovation, especially in Africa, for addressing NCDs. The third one is local adaptation of solutions to against NCDs burden in Africa. The fourth one is encourage collaboration for African countries. Then we have to inspire actions for African. With our panelists, starting from Ndoli, is a passionate health tech entrepreneur and nutrition expert dedicated to transform healthcare through innovation. She's a co-founder and CEO of Lifesten Health, and she used technology to make personalized health screening more accessible across the continent. With over 7 years of experience, she led an innovative funded project that screened of 2 million of Rwandan children using cutting-edge emerging technology. Recognized with multiple awards, including Innovators of the Year 2022 and the Africa Women in Digital Health Award 2024, Peace is committed to advancing preventive care and equitable health solutions across low and middle-income countries. Please, everyone, join me to welcome Peace in our discussion. The second panelist is Dr. Funmilola, who is a passionate in breast and general surgery. She's an educator and cancer researcher dedicated to improve cancer care in Africa. She graduated from University of Ndoli and surgical, and she's a surgical fellow of Western African College of Surgeons. She has trained globally from Harvard to Toronto, earning advanced degrees and certification in surgery, research, and genetics. Now, she's a senior lecturer and consultant at Obafemi, Awolowo University. Please allow me also to welcome Dr. Funmilola in our discussion. Our last panelist is Dr. Mike. Dr. Mike is a dedicated physician and global health expert with over a decade of experience serving community in especially those who are in crisis in Africa, Asia, and the Middle East. She's now an advisor with Médecins Sans Frontières, and he's responsible to outbreak like Ebola and COVID, while tracking long-term health issues like malaria and undernutrition in Africa. With training in medicine, public health, and data science, he combined clinical care with strategy and innovation, while also passionate about equity and digital health in Africa. So please, everyone, help me to welcome the panelists for discussing now on the global innovation and local solution in advancing NCDs care in Africa. Please feel welcome, all panelists. Let's move to our discussion. By now, let's start by discussing on the current state and the height of the burden of NCDs in Africa, so that we discuss the state challenge and any opportunity in prevention, management, and treatment of NCDs in Africa. Let's start by Peace, so that you share your insight with us. Let us know, please, what are the primary drivers of the raising of NCDs in Africa? The floor is yours. Peace.
Thank you, Michee. Excited to be here. Please confirm if you can hear me.
Yeah, very well.
Thank you. So, yes, thank you for having us and for this very important conversation. So maybe I can start with a little bit about my background. I've worked as a nutritionist in both public and private facilities in Rwanda, where I'm based. And I believe that was my first engagement with NCDs, but I'm not necessarily a big fan of how the healthcare system addresses NCDs at the moment, specifically because most of the budget, most of the funding is still being allocated to communicable diseases. Yes, we still have those, but it's taking us a very long time to realize that NCDs are coming and we need to be ready for now the biggest, one of the biggest public health issues at the moment. So my biggest concern was that there was lack of information when it comes to NCDs in the overall population. So my angle with the company I started was to bring awareness and early diagnosis and make it as accessible as possible. Management is still important. I do recognize that, but I feel like all these diseases, as they say, they're silent killers, and it will make a very big difference if people had access to information and if they knew these diseases are preventable to a certain level. So that's why we started Lifesten with an aim to reach as many people as we can, especially people who are not reached by the current solutions, who don't easily access diagnosis or information on diabetes, hypertension, etc. So in Rwanda, we started with those two, since they're the leading NCDs. And currently, at the moment, in Kigali, Nairobi, and most cities in East Africa, the NCDs contribute to 6 out of 10 mortalities. So, and there is a really big burden when it comes to hospital admissions, going up above 55%. And so there is that burden either to an individual level, but also to the healthcare system at large. And we wanted to make access to information and access to care as close as possible. So our angle is divided into two. We have a community-based approach and a digital-based approach. And the community-based is that we train agents, what we call Lifesten ambassadors. So We intentionally pick like leaders in different communities, churches, bus stops, choirs, schools, etc. And then we train them on the basics, risk factors, and then give them a link to community health workers or facilities that can really help. And then after that, we give them access to screening tools that they can use in their own communities so that we facilitate that whole process and be able to connect the people who are sick to the health facilities. So for the digital part of it, we've designed incentive-based programs so people engage with different activities under nutrition or physical and mental health. And then it's gamified, so the points they collect over time are redeemable for actual services, like free passes or discounts on different screenings, nutritional screenings, gym membership, so that there is at least that award or that motivation that comes from you're taking care of yourself and you deserve something. And we've seen this work. And one additional thing we've been trying to bring on board is the community aspect. We have communities. So people join an existing community or create their own. For example, we have a community for pregnant mothers. So they get to ask questions about literally anything. And then a healthcare provider can provide information. And then we give them like personalized activities that are favorable depending on their conditions. So yeah, that's what we do in short. And so we mostly focus on the angle of prevention, increasing awareness and access to diagnostics. Thank you.
Thank you, Peace. I think we are still on the point of primary drivers to NCDs in Africa. Can you please let us know a little bit about socioeconomic factor in terms of NCDs care in Africa?
Okay. So I think we all know that I would say especially for low and middle income countries, our experience is really different compared to developed countries. And when I started, I mentioned how sadly our system is now still very focused on communicable diseases, and there is less or no focus on NCDs. And this is primarily because of we still view, as a society, we still view NCDs as rich people diseases or white people diseases. And these are things that have come up sadly in a lot of conversations, whether research or even in the healthcare system itself. So we fail to recognize that we're developing, especially in cities, we're developing. So people are driving to work, sitting for 5 hours, driving back home. And it comes from the angle of people still look at if you've made it in life, then you're eating meat every day, you're eating fried things every day. And it's those, I'll say, small things. And it has come to a point where, like developed countries, the people who don't necessarily who are still below the poverty line are struggling because now they're in cities. They're struggling to get access to healthier food options as it was a while ago. The assumption was if you live in a village, then you have access to fresh foods, fresh fruits, fresh vegetables. But it's not the case anymore because people are moving into cities. There is development, which is a good thing, but then modernization comes with limited access because we're squeezing ourselves in small cities. Access to food is different. So people end up going for the less healthier options. And with this, sadly, with these challenges, it also comes with a time where our systems are still struggling in terms of human resources or financial resources to manage everything that's happening. So yeah, that's what I'll say about the leading social factor that I see is that there is modernization, but it's not being balanced by the information that is being provided.
Thank you, Peace. Thank you for sharing with us your experience, your work and your organization. Thank you for contributing to the Africa community health. By Dr. Mike, I think we are now on your side to share with us the most significant gap in NCDs prevention strategy across the continent. What are the most significant gaps which are there in Africa for NCDs prevention?
Maybe just put some perspective, because again, like, what's this guy that has been working in humanitarian space doing here? So yeah, so I of course I've been in the humanitarian space for years, right? But again, I'm also the co-founder of Innovate Earth Hub, which is kind of a hub where we try to kind of encourage young Africans, right, to innovate, and this also came from the fact that we've seen gaps, of course, in all this, and we also saw the need that for Africa to go to the next level, there is need for innovation, right? And and that is one thing I found interesting about this webinar, is that also we're talking about homegrown innovation. This is what we do in Innovate Earth Hub, right? Talking about what are the gaps. I think I love what P said. I mean, Uganda and what is happening over there. I think, yeah, just to give some background history, right, to put more perspective, is that, just to also pick up from where you talk about infectious disease, which is where I work, basically. I'm an infectious disease malaria advisor. So if you look at Africa, right, if you look at in the last 2 decades, right, we've seen, of course, in the early 2000s, we saw a lot of investment, right, in infectious disease, right? So you will have heard about the Global Fund for HIV, TB, right, malaria. That was a lot of investment. You heard about the PEPFAR, right? But again, we also, over the years, we've seen some shift in, what's called transition, epidemiological transition over time. Now that we still have the malaria, we still have some of these infectious diseases, right? They are not gone, they are still there. But again, on that, we are seeing a lot of non-communicable diseases. And let me shock you, right? As a young, I think, final year student, medical student, I did, one of my research topic was prevalence of diabetes, right? And in Nigeria, somewhere in Nigeria. And after this, I was surprised, because I was looking at the prevalence of diabetics among market women where I was schooling there. And I was shocked, by the finding, and only few of them, because some of them actually were diagnosed on the spot and all the stuff, only few of them knew that they had diabetes, and only few of them have access to care, right? So we have moved from what I call largely infectious diseases, that is still with us. I try to call that the protracted infectious diseases, right? And now we are having this NCD on top of that. For Africa that's still struggling, the health system is still struggling, that is a double burden of disease, right? So we are not out of infectious disease. Now we have NCD. Now, what are the gaps? Of course, the gaps have not changed, right? So we have gaps of HR. So one of the issue about NCD is the fact that at some point, it is always been looked at as a specialized field, right? So, you need to see a specialized doctor to be able to treat your diabetes, and of course, that also created a bigger gap, right? Of course, this is changing. I work with MSF, and one of those things we've been able to achieve is also what I call decentralized model of care. Of course, probably we'll discuss that later, to be able to ensure that people have access to care. But the care is still not there yet. If you look at the population of Africa, if you look at the available health facilities, or, you see that there is big gap in terms of access, right? So access is one, and this access, of course, if you look at it, it has different layers, right? So you talk about the shortages of health workers, if you look at, for example, if you look at doctors, not saying that doctors must always treat NCD, but if you look at that statistic, you realize that in Africa, we have about one doctor to about 10,000, right? Of course, it varies, but sub-Saharan Africa, you see this range. It means that if you are looking for a doctor to treat you for NCD, which should not be all the time, then of course you might probably not get that, because the doctor are already overwhelmed with what is going on. So that is one big gap that we'll be looking at. Another big gap is also, I love when Pete was talking about education, is the fact that even the people don't know about it, right? So because if you look at how NCD happens, it's a silent killer. It's not like malaria. Then you have the fever, except probably if you have some complication of diabetics, and of course you have hypoglycemia, then you need to coma or something. Which of course, you realize that people don't even see it as a big challenge. So there is also this kind of information gap in Africa, right? Then the other part again that I'll quickly say is also there is lack of data. Because again, we're talking about innovation, which we'll come to later, is the fact that we have some estimated data to say this is what is happening. But if you look at more granular data to look at some sociological changes, you might probably not get this kind of data to be able to make this kind of decision. Then finally, of course, as we all know, is there is lack of investment, when it comes to NCD. And that was why I gave that history of the fact that we had a lot of commitment to infectious disease, in the early 2000s, then coming to now. And, it's quite unfortunate that we are at a time where funding is also being affected across the world, right? You must have heard about the decourt of USAID. You must have heard about some other things that's happening. What this is telling Africans is that we are going to see less investment in healthcare, and this is why, for me, innovation is just something we need to look at. So these are the gaps that for me that are currently challenging healthcare when it comes to NCD in Africa. So I will stop there so that other panelists can also contribute to it.
Okay, thank you, Dr. Mike. You highlighted something like gaps like information, data, investment. But one of the recommendations for improving African health is community-based initiatives. So from your perspectives, what the role of community health initiatives play in closing these gaps? As you mentioned, so many gaps. What are the role of community-based initiatives to address those gaps?
Yeah, so again, it's also to look at what data says. I love data so much, right? So if you realize most of the population of Africans, right, or in sub-Saharan Africa live in the rural area, right? And if that is the case, then it means that whatever healthcare design you are looking at, you must also focus on something that goes to the grassroots, that goes to this rural area, right? So one of the things we've been able to do, in my organization is something I talk about, the decentralized model of care. And let me tell you how this works. It's more of also borrowing from the experience of what we've done with HIV. One of the successes of HIV is the fact that we've been able to decentralize care, and not just decentralized care, we've been able to take care to the community. What people would call maybe patient-centric, care, or you say community-centric care. And I will give you an example. In South Africa, one thing that was done with HIV, which of course is also replicable in NCD, is the fact that HIV is chronic disease, right? Of course, most NCDs, they are all chronic diseases, right? Then we've been able to educate communities, and because of the fact that these people work in group, they can always, for example, have a focal point that can get their drugs from a facility and take it back to the community. Now, what does that do is that, of course, it reduces the need to commute from, maybe this far place to the health center, right? That is one. Another one, again, is also the fact that because this is chronic condition, right? When you give the right education to people, I can tell you that they know what to do, So what I'm saying is that you have to put healthcare in the hands of the patients, as we always say, right? So you have to educate them to know what to do. So these are more community strategy. But now coming to the facility itself is what I talk about, the decentralized model of care. Now, what does that mean? So diabetics, as a doctor, I also know that, of course, that diabetic care, of course, at some level, there is need for specialized care. But the baseline diabetic care, of course, can be handled by not anyone, but a trained health worker, right? So what we do is that we've been able to simplify protocol for managing some of these NCDs, right? In a way that even nurses at the primary healthcare level can manage cases. Uncomplicated cases, right? And this kind of decentralized model has been able to increase the access to care, to people living in some of these hard-to-reach area. I think for me, these are some of the community strategies that we can look at when we talk about NCD.
Thank you, Dr. Mike. Thank you for highlighting how we have gaps and how we can contribute to those gaps. Let's move to Dr. Funmilola. Is the name right?
Yeah, that's
Funmilola?
good. Yeah,
Okay.
it's Funmilola.
Please share with us what policy changes needed to improve the treatment or the management of NCDs in Africa.
Yeah, thank you. It's a pleasure to be here today to talk about this burning issue. And for me, my background is more in non-communicable disease, especially cancers. So majority of the patients that I see are breast cancer patients because I'm a breast cancer surgeon. So I'll say that just like the two other speakers has alluded to it, there is increasing number of non-communicable disease, especially in Africa. And we still have our infectious disease, as rightly stated earlier. But unfortunately, we don't seem to be meeting the gap yet on how to take care of this burden of disease. And that's because we have so many of our own challenges, but there are so many other good things that are happening in Africa that can actually help to move this forward. We are a community-based kind of people. What do I mean by that? I listen to what my grandmother says. My grandmother listens to what her friend says. So we have this community of practice that we actually listen to. And I think if we leverage on that as a community by finding a solution to our own problem, that will be a very important way to go. Not diverting away from policies. I say in Nigeria, we have what they call a cancer dex, where the health policies are being refined and made, especially when it comes to cancers. So I'm aware that we have different policies across Africa that is aimed at improving outcome, especially when it comes to NCDs. And like the earlier speakers have alluded to, NCDs, usually if the preventive stage is the best stage, when you can prevent before it becomes the harder burden and all that. But our policies, or let me say our implementation of the policies are a little bit weak. So when you go to our Ministry of Health, you see amazing policies about different diseases, how it should be treated. But when it gets to the community itself, how it's being implemented is where the problem comes to. Because some of these preventive measures, they need active government intervention. That is, you need government to have a lined up things about how do we go about it. I keep telling people to come and screen for breast cancer. Mammo has been shown to help in screening for breast cancer. But how many centers across my home country, which is Nigeria, have mammogram? So the places that have mammogram, how many of them have breast radiologists that is going to review them? So you see that it's not enough for us to make policies, but when we make policies, how do we implement them? And I think that's the major gap that we have in Africa. Policies are there, but they are not being worked on so that it becomes more useful for day-to-day activities of everybody. Yeah.
Thank you. Thank you, everyone, for sharing your insight on the burden of NCDs in Africa and how you feel, and the highlight on it, and how you feel can improve the NCDs in Africa. Let's move on to the innovation, how innovation work in NCDs management. Let's talk about, especially on digital health solutions, telemedicine, AI-driven technology, so that we respond to the NCDs in Africa. Come back to Ndoli, please let us know what are some of the most promising global innovations in NCDs care today we have in Africa.
Okay, so innovations. And I think I talked about this briefly, that with the already existing challenges, we need to look at other angles if we're to tackle this. And one of them is innovation and technology, to look at the different technological advances and how we can use them to bring the best outcome possible, especially when it comes to NCDs. So I'll talk about two technologies I've worked with so far that are used for NCDs. So in my organization, one thing we've tried is look at solutions that are working for the West and then find a way to contextualize them for our market, train the models so that it works for our own people. One of the challenges we've met so far, which was expected, was we integrated a first screening, blood pressure monitoring and screening tool. So it can be used as a diagnosis tool for people who are not already living with NCDs. It uses a technology called transdermal imaging, and what it does is simply reflect light to your face, and then it's able to detect the blood flow under your skin. So that has been used to elevate the burden of limited access to diagnostic equipment, especially in rural areas. But also, one of the challenges that came up is that because it uses light and it wasn't necessarily trained to darker skin tones, there were a lot of challenges when we started using it. But over time, with the training and bringing on board different stakeholders, then it got to a higher level where we've done a couple of research on the tool, and now it can be used as a diagnostic tool for on the population level to see. You get around 13 key metrics, but for us, our focus was blood pressure. Another technology I can mention is by a company called Biospectral. I participated on it through research, and you simply use your finger on the back of the phone, on the torch on the back of your phone, and then it's able to get your heart rate, blood pressure, etc. So sadly, we don't have a lot of AI, specifically NCDs, diagnostic tools in our market. And one thing I truly believe is that no one has to invent something from zero. And this is where partnerships comes in. So how about looking at existing solutions, existing technologies, but working with them so that they work for our market, so that they're relevant and contextualized to the people we're serving. So all these, in 2023 to 2024, we're working on a citywide project, and using technology allowed us to reach so many people who don't have the time to show up at hospitals or who are uncomfortable with hospitals, which makes sense looking at the experience when we usually use our health facilities. But also with the use of, I liked what my colleague says, that we're very community-based society. So every single thing you bring, if you attach that community aspect to it, then you're able to reach as many people as you can. So when we're using this tool after training it and getting the accuracy level we're looking for, then we just needed one person in a family who has access to a smartphone. So for everyone else who doesn't have access or who is not comfortable with technology, then that person acts as the focal person for anything NCD. In a way, they're gaining information that they can use on the individual level, but they also become like a library for the whole and a point of care for the whole household or community. So that's the angle. We can bring in all these technologies, but the most focus is, can they work for our communities? Can they be contextualized to our culture, to our ways, and basically what our communities are looking for?
Thank you, Peace. Thank you for highlighting the importance of innovation in NCDs management and how the technology can help to detect NCDs early as possible. Let's move to the Dr. Mike. Dr. Mike, are you available? Please let us know the impact of technology, especially telemedicine, on NCDs care in Africa.
Yeah. So the impact of telemedicine, I mean, of technology on NCD actually, is an opportunity also to experiment, right? If you look at NCD, it's chronic condition, then it's an opportunity, and we saw how technology, particularly telemedicine, also we saw a lot of adoption during the COVID, also even in Africa, which shows that it is possible, right? During COVID, we saw a lot of people that couldn't get to the facilities. They were, able to contact their doctors via either phone call or telemedicine. And I believe that this is also possible with NCD. And and as I said earlier, if you look at the proportion of Africans living in rural area, then you will see that there is need, of course, to ensure that we get access to these people. And one thing I believe is that one of the advantage that we have is also the fact that we can actually be able to scale up, access to care through technology, particularly for NCD. And, I'm always very careful when we talk about telemedicine because, telemedicine looks like a big thing, but even something as simple as using your phone to send SMS as for follow-up, all those can be that they are practical steps that, this can help. And we've seen it not just in Africa, we've seen it being used even across the world, right? And also, if you look at NCDs, also that there is continuous need for, monitoring, right? So, so this is also an opportunity, with the use of technology to be able to monitor, to be able to get feedback. Of course, there will be challenge with acute symptoms, of course, which might still require physical facility, so it doesn't really rule out the fact that there should be also investment in this. But with technology, we can be able to kind of scale up access to care for NCD, basically in particularly those that are living in rural setup.
Thank you, Dr. Mike. Thank you for sharing your insight and letting us know the use of technology, especially for monitoring the NCDs, getting feedback from our treatment, and have access to care, especially when using technology in NCDs management. Thank you very much. Dr. Funmilola, please share your insight on the ethical and infrastructure challenges of AI integration. Sometimes we have AI, but our African ethical and infrastructure can be a challenge to AI integration to NCDs management. Please let us know your thoughts on the ethical and infrastructure challenge of AI integration in terms of NCDs management.
Yeah, thank you. I think one of the things we need to know is that artificial intelligence has come to stay, and we are the one that needs to meet up with whatever it is that is doing. And globally now, artificial intelligence is being used to enhance diagnosis specifically. And I think I can talk a little bit about what is happening in the field of breast cancer, because AI is being used to help the radiologists to be able to pin down lesions on the mammogram, on MRIs, and these are giving results that are really close to what human being would detect. So it shows that if we really manage this revolutionary change very well, we in the low middle income country are likely to gain more from that. And the reason is this: we know we have very limited number of healthcare professionals. We have very limited number of people that actually super specialize in diseases. And the reason is because when you need to have a super specialization. That means you have to be a generalist first before you do that. So you need a number of people. So actually getting people to be super specialized is a little bit difficult because of the other issues around it. So if we can leverage on the way artificial intelligence can help to improve diagnosis and prevention, that might help us in covering a large area of places that would normally will not be able to get to. But when it comes to the ethical consideration, I think like everywhere we know that humans still takes responsibility for whatever is happening when it comes to the use of AI, because humans are still the one that is expected to control it. It's still the final say, the final issue that comes from it still falls on the human being that is overseeing it. So we need to have like a well-formed ethical commitment to it. And presently, I think this is still in evolution. Even in high-income countries where it's starting to get to use, every day, people, the ethical consideration are changing. How far do you allow these machine information to inform how you make decision for patients? And how far do you as a physician take responsibility? And I think this is the right time for us to start the discussion to a low middle income country. What are the limits that we expect AI to go when it comes to making diagnosis, when it comes to treating patients, when it comes to giving information out to patients? And I'm happy that recently there was this study that was going around the world, and some part of Africa too were part of the study, where patients were asked about how they will feel if artificial intelligence is used to enhance their diagnosis. We're still waiting for the results, but data were collected around just to ask people from different parts of the world, Africa inclusive, what will you feel like? How do you think AI can help your disease and diagnosis? And what are the things that will bother you? Because we need to understand that I, as a physician, might feel that there's no big deal, but what does my patient feels? They are the end users. They are the one that whatever information I'm giving gets back to. So I think the ethical consideration is still in the pipeline. It keeps changing, but we need to know that we have to be responsible in the use of these things, and to know that because AI said this does not mean that it's 100%. There should be a human that supervises what we are doing, and we need to be intentional about that.
Thank you very much. Thank you for everyone for sharing your insight on the use of the innovation in NCDs management in Africa. And now we have gained more, and the audience is ready now to express their questions after the discussion. Let's move to the local adaptations of solutions to NCDs burden in Africa. Let's start from peace. Please let us know. We have now you have global innovations and you have local settings. Please share with us the key considerations you think is important when adapting global innovations to local settings, and if possible, share with us the example, one or two, of successful localized NCDs interventions.
Thank you. So I think I shared an example already. So I'll start with how do we localize digital solutions, especially that are targeting NCDs. And the first thing is what actually Funmilola just mentioned, the giving power to the people, to the patients. What do they need? What are they comfortable with? I think over time, our system has been trained to look at, we treat patients as, I'll say, the healthcare system makes the decisions, and then you just have to follow whatever is happening, whatever rules they've set, you are a follower. It's very normal to walk in a doctor's office, and then before you even know what you're suffering from, they're just like, buy this medication. You have nothing in the matter, you don't know what you have, you don't know what it means. And even for the people who are brave enough to ask, what's wrong with me? You'll get like one sentence. You drink a lot of water and sleep well and drink those medications, come back in 3 weeks. So we've not learned that giving power and some control to the people we're treating or the people you're helping, and that takes away a lot, especially because in the mindset of how people approach this whole health and wellness angle. So it's not, they feel like they have zero control on what they can do and the decisions they can make and how that is going to affect their health outcomes. So the first thing, it doesn't matter what the solution is, what the innovation is. It needs to be localized, but not just for if it's for a hospital setting, obviously, for the doctors, the healthcare providers, they need to be comfortable with the solution you're bringing. But sadly, that's not how it's done. Someone will sit in their own lab, in their own office, design something, sell it to the hospital, and in the next Monday morning, you'll be told that you're supposed to be using this moving forward. But that system doesn't work for the type of work you do. But as, let's say, a procurement officer at this hospital, I have no idea what your day-to-day looks like, what activities you do looks like. And for me, it just makes sense. It sounds like a groundbreaking AI that's going to change all the issues we have. So if it's being designed for the healthcare providers, it needs to be designed with them. You don't bring it when it's ready and expect someone to adjust whatever they were doing so that they can integrate this whole new thing. But if it's also being designed for the end user, the customers, the clients, or the patients, then it needs to be designed with them. There is this research theory that says the knowledge is with the people with the lived experience. So the person with the lived experience, if it's a patient, that's the person who knows all the pain points that might be elevated by this technology. So they should be part of the designing and not just part of I'll acquire whatever solution you bring to my table. So for me, that's the first step. Who are you designing this for? And are they part of the designing? Or are you just going to impose the solution you've designed just because it's a very complicated and very innovative technology? That's one. But also the second thing is also looking at the data privacy, especially when it comes to these new technologies. Where were they designed? Who has access to all this data? What is it going to be used for? Where is it stored? All that information. I think usually it just stops from we're collecting data, especially for AI-based diagnostic tools. We're collecting data. These are the results. That's it. But how can this data now go on to inform either future technologies or policies that are in line with the NCDs or the diseases we're focusing on? The last thing I'll talk about is the integration of innovation in medical training. I think I'll generalize this. Mike and Funmilola can correct me. I think in the African setting, most medical schools, innovation is usually left out of the window. It's just how the education system was, I don't know how many years ago. Usually it's the same thing. This is how the routine has been. This is what you're supposed to follow. And in areas where even innovation is introduced, it's usually a theory. I've seen a lot of cases where someone comes in, they get to the hospital like a fresh medical graduate, they come with ideas, they've learned things, they've learned doing a couple of things, but then you get in, you find 50, 60-year-old with 40 years of experience, and they're like, slow down. That's not how we do it here. This is how we do it. And you're supposed to follow how they do it if you're going to last in that career. So innovation is, I'll say it's not encouraged, whether you're still in school or practicing. And it makes sense. From my angle, it usually makes sense. We are not in an area where we get to try and fail. You're dealing with people's lives. So you can't be playing along with whatever comes along. So there need to be regulations on, we have a room to try things, but also abide to the ethicals and the different rights that protect the patient. So we need to find a balance between the two. And I'll stop there and pass it on to the other panelists.
Thank you, Peace. Thank you for highlighting the importance of giving the power and the full right to the patient, for involving local community to the program design, and emphasizing on data privacy and integration of innovation in medical training. Come back to the Dr. Mike. Now in Africa, we have like two things which may interact with innovation in negative way. Like, let's say culture and behavior. From your insight, let us get more insight on the integration of culture, African culture, and community behavior with NCDs management, especially how culture and behavior can interact with NCDs management, and how this can affect the effectiveness of NCDs management in Africa.
Yeah, thank you. Yeah, one that comes to mind, of course, is stigma, right? So if you look at the concept of NCD, if you know that it ranges, of course, from, it also include mental health, of course, which is also something that comes with a lot of stigma, and even the cancer also that we're talking about. Stigma is a big one when it comes to cultural perception, of NCD. And also, again, is that when people are told, especially for those ones that are chronic condition, they are told that you have to take this drug, it's a lifelong treatment, people find it difficult, and also you need to also appreciate that Africa is quite a religious community, right, where people always draw some spirituality, especially when it looks like, oh, you have to live all your life doing this. So yeah, so culture itself, even though of course we have the positive, where communal people, which of course help in fostering this kind of care. Again, it has also it has also prevented people from seeking care in itself, at the facility. Another point also is I think again, which has also allowed some cultural myth, or what I call perception, to foster, is the fact that there is lack of understanding, or I would say education on the causes of some of these things, right? So yeah, so you have, for example, you have cancer, so people attach a lot of spiritual causes to that, so which also make it difficult for them to seek care, So if you don't understand that this is treatable, or you feel that, oh, this is because of the fact that I've done something wrong, so this is more like this is coming, So people don't seek care, right? Then also is the fact that even in the treatment itself, we also have, everywhere you go, you see this. Of course, not to be too critical about that. You see the use of herbal treatment, of course, that are not regulated also, and this of course, deter people from seeking care when they have this. Then, of course, this is all about culture. Again, is also the fact that in some places also, even when you seek care, which is of course maybe something on the health workers, that they don't get the right information, right? So if you seek care and you don't get the right information, then you are liable, or you are likely to come up or to conjure some things to explain this. Then the other question is that how can we shift? I think for me, the first one is education, right? Education. And I think I also love the fact that we are talking about prevention, which of course is cheaper, as I always say. Prevention is better. So it is also to put a lot of emphasis on the fact that this can be prevented, right? And this also has a lot to do with how we live our life. What we eat, of course, which also might be a little bit of a cultural kind of cultural thing that might push people away from actually seeking care. So what we eat also, we know that some of these things, of course, risk factor for some NCDs. So, so education, I would say education is one. Then the other one, again, is that, and also is also from experience, from what we've seen is also, I think there is also need to start looking at what I call patient group, So patient group is a kind of a strategy where people that are already diagnosed, and of course they've accepted their diagnosis, they are on care. We can also use them as more also to be able to talk to other people, to be the lead, in terms of educating people that, okay, this exists, one. Of course, there is also kind of some kind of treatment for it. And then lastly also is, I will also talk about the fact that we need to look, I think the other speaker also talk about culturally acceptable model of care, and, because for me, one thing I've seen in terms of developing care is that we tend to pick, of course, it's nice to pick from the Western world to see how things are done. But again, if you pick something from the Western world and you go to probably Northern Nigeria, you might have some cultural challenges there. So in as much as also we are looking at the fact that, okay, culture might be an hindrance, we should also look at adaptable, solutions. And I will say also, like other speaker says, that these solutions should involve the community. So as long as the solution involve the community, there is likelihood that it will be accepted by the community, and of course they'll be able to follow through. Yeah, thank you.
Thank you, Dr. Mike. As we know, to enhance NCDs management, we need both government and private sector. Let's now move to Dr. Funmilola to share with us if we have now both private and public sector in scaling up the innovative solution for NCDs management. Let's go to the role of public-private collaboration. How public-private collaboration play a role in improving healthcare access and strengthening the local health system in Africa?
Yeah, thank you. I think the role of public-private collaboration cannot be overemphasized. And that's because if you look at almost everywhere around the world with very good healthcare services, the private sector plays an important role in it. It's always very surprising to people when they hear that some of the biggest cancer centers in the world are actually privately owned. But the privately owned spaces cannot function well if they don't have good public collaboration. What do I mean? You need government backing for everything, because just one government policy can ruin a whole lot of stuff. So we need the government and the public to partner together, and everybody has different roles they are going to play. Sometimes the public space is to provide policies, provide an enabling environment, and provide enabling environment, whereas the privates might be bringing more of the money, the expertise, and this will help for everybody to have an interplay. It's easier for you to do some kind of innovation in a private setting, but you need the public sector to collaborate. I work in the public sector, and I see that there are some public-private partnership already working within the hospital, and that has improved some access to some kind of healthcare. There's some kind of diagnostic machines in my hospital that were more of a public-private partnership, and this has worked well compared to when they were solely in the hand of government. And that's because the public space have a different how I call it, like mission statement, which is different from what the private sectors have. So sometimes some things are better driven by privates rather than public. So I think in healthcare systems, so the same thing will happen. We just need to strengthen how this collaboration works so that nobody feels edged out. And again, we strengthen in such a way that patients are protected, so that we don't bring people that just want to exploit patients at the expense of their diseases or their money and all that. So I think a public-private partnership, when well managed, is going to improve our local system, is going to improve the healthcare care. If I use Nigeria as an example, you see that there are some, recently, there's a robotic surgery was done in the country, and this was carried out in a solely private center. And I think the next phase will be for how does government help the center to do better, in which they make them like a training center where people can go for a very specialized kind of training in robotics. So you get the private sector is likely going to lead way, especially in the newer innovations. And I think a buy-in of the public sector will really go a long way and help us improve our healthcare system.
Thank you very much. Thank you, everyone who shared the insight on the adaptation of community and involve community in NCDs management, especially for community to engage themselves to the solutions of NCDs burden in Africa. I really enjoyed your responses, but meanwhile, let's remind the audience that you can now post your question in our chat or be ready for a question after the discussion soon. Let's move to the collaboration of different stakeholders as a response to address NCDs in Africa. First of all, why collaboration is very important, is critical in addressing NCDs crisis in Africa. What do you think?
I think they've just talked about it. The things that work for the public sector and the things that work better in the private sector. So when we're able to bring those two together, then we strengthen what's working and also we're able to reduce the weaknesses that might be on either part. And one thing I'll talk about is partnerships don't necessarily just stop on the public and private space. It also comes to the innovators, the people we're talking about, the people who are designing those solutions or who are bringing solutions from elsewhere. How do we reduce the burden of entry and make it easier for the available solutions to be integrated into our system? Because truly that's something that's not being done. And what this does is that it reduces the number of people, especially healthcare providers, who are willing to work on solutions, test solutions. And the reason why I say this is because most of the solutions we have in health tech that are targeting NCDs or other healthcare issues, in most cases, they're not designed by healthcare providers. They're designed by tech people, if I may call it that. They just look at the problem, oh, we have a big number of people dying from this, what can we do about it? So if as the healthcare system, if we give this power to the developers who have not learned anything about the medical ethics or anything close to that, then also the quality of the solutions that are coming to the market, in one way or the other, they're questionable. But even the healthcare providers who are designing the solutions, what are the available incentives or infrastructures that allows the solutions to be tested in the system? An example I usually like to give is the fintech industry. The fintech sector is really, really open to innovation. And we've seen over time how we quickly moved from our parents, I think they used to write, withdraw how much we've drawn. You used to have a book with all your expenses, tracking your expenses. That was your whole bank. But a few years ago, we've seen how the money conversations have changed. You can do every single thing on your phone. You can do in-country and out-of-country transactions. And all these innovations are not necessarily being developed by the banks themselves, but they're willing to look at what are the developers, innovators out here working on, and then making it work for the system. But they're open to the innovation. Sadly, it's not the same case with the healthcare sector. every single thing that's new is usually pushed away. It's a very comfortable space that has worked in solos for so long that now we're very comfortable with just building a very big wall between the healthcare system and any other sector. And I feel like this takes away a lot that might have happened if we're able to engage the innovators, be part of the co-creating, but also bring, I usually call them unusual partnerships that are not necessarily part of the healthcare system now. This can be infrastructure. One of the new emerging sectors in developed markets is architecture for health. How do we build hospitals that speeds up the recovery or something? How do we build hospitals cannot be built as churches or schools or anything. And that's a whole new thing. But I don't know how long this is going to take for it to be integrated in Africa. In Rwanda, they're building the first heart center, the biggest in Africa. And they were very intentional when it comes to this architecture. But I feel like 10, 20 years ago, if you were to say, how can the infrastructure ministry, for example, work with the healthcare ministry? They're like, what are we talking about with them? So we need to have this new way of approaching things. Don't look for how things were usually done, but look at how can we engage every single person who is on board, and especially those who are not on board, to provide the best care possible to as many people as possible.
Thank you, Peace. Let's move to Dr. Mike. Now, in our system of NCDs management, we have policymakers, you have researchers, you have healthcare providers, but we are still wondering how all of them can align their effort. And we need your insight on the mechanism which can help for sustained engagement of all sectors, including policymakers, researchers, and healthcare providers.
All right. Yeah, I think I will start with the fact that I think that also has been stated is also the fact that in Africa in general, you realize that healthcare is driven by private sectors, right? And this also was quite obvious, during COVID. We have a lot of innovation that came from the private sector, meaning private healthcare provider. And what that means is that if we want to, kind of move to the next level, where healthcare is accessible, then there should be kind of regulation. And this regulation, of course, comes from the policymakers. So, there must be an alignment. First is defining what the priority is, which of course also comes from the policymaker. So I don't think personally that NCD has really got to that level that, we have seen a lot of investment in time and effort and even investment in fund, So I think we need to get to that level, to say NCD is an important part of our healthcare, of course, not also neglecting others. When we get to that level, then the other level is also what kind of regulation do we need to put in place that will make this sustainable? Because one thing I've come to realize is that if there is no enough regulation, of course, you might end up not getting the perfect fit, for the health system. Then also another one is also that I think also there should be some kind of encouragement, for these other partners, which of course will come from also the policymakers, which involve the government. And so in alignment of policy and also alignment of innovation, of course, that is driven by private sector, we also provide the platform, for accessible care, for the people. Now, talking about sustainability, I think, I've always believed that, the best way forward when it comes to sustainability, either in form of innovation for healthcare, is co-creation, right? So the concept of co-creation is also that, it's just not coming from one direction. It's also that all the relevant parties are on board, including the community. So if you're looking at talking about sustainability of an innovation around NCD, then the policy maker must be on board. Then, of course, the innovators must also be encouraged. I think one of the speakers talked about the fact that one of the challenge of innovation in Africa is the fact that there is no room, that encourages innovation. In what is termed, psychological safety. For some of us also that went to medical school, where you cannot come up with an idea easily or scale up an idea. I think to look at sustainability, there should be kind of a playing ground that encourages people to innovate, and also not just innovate, is also to ensure that this innovation is adaptable to the community to ensure sustainability. Thank you.
Thank you, Dr. Mike. Now, let's gain another insight from Funmilola on the international organization. International organization is one part of stakeholders in Africa, and it plays a major role in our healthcare system. So please, Dr. Funmilola, share with us the role of international organization in strengthening Africa NCDs responses.
Yeah, thank you. As we know, international organization plays significant roles in low-middle income country. And like one of my good friend put it recently, she said, when they sneeze in America, we are catching cold in Africa, which is the sorry case of what is happening with USAID. Showing us that international organization plays significant role, but it is time for us in Africa to take the bull by its own, as in we have to be ready about what is important to us so that we don't get to keep relying on other people 100%. Why we need international organization, but we also need ourselves. And one of the roles international organization plays is actually to help us put things in perspective and to take us at par with everybody as what is going on around the world. And we also know that for all these innovations, we need funding. And I think that's where most international organization comes in. They comes in with expertise, they comes in with funding. So I think while we have a good relationship with them, we should also, as a community, be ready to have strategies that will help us enhance how to improve on the NCDs generally. Because sometimes, if you notice very well, every funder or every organization has their own mission statement. They have what they want. So sometimes you might be tempted to play the role what the person giving you the money wants, or the person bringing the expertise. But I think it is high time that we sit down to find what are the things that are major problem to us. How do we incorporate how do we incorporate new strategies around digital health, AI innovations? How do we engage it to our context? And I think in doing that, one of the ways that can help us is to really know, to have this, what we call community involvement. And community involvement is in different levels. It could be at the level of the healthcare workers themselves, like with the organization they are working with. It could be at the level of the end users of whatever products you are willing to do. That's the community where you want to use the product. It could be the patient, or it could even be other factors that improves uptake of new innovation. Like Dr. Mike said the other time, he talked about the fact that Africans are deeply spiritual. Sometimes I find it interesting the role our religious leader plays in how people accept care. So sometimes those might be the people you need to involve at the initiative space. So I'll say that international organization, yes, they plays a role, but we ourselves need to know what we need them to do and what our people are likely going to accept. So there has to be an inward introspection on what we need, and then that should align with whatever the international organization that is going to work together with us, so that will strengthen our response to NCDs in Africa.
Thank you very much, everyone. And as we're moving to the inspire of action for the African community, we have questions in chat box, and I think some of participants they have their own question. But please, we are about to finish and start answering your question later. Please stay patiently. So let's inspire for action, starting from Ndoli, please. Please share with us the urgent move. What is the major next move required in Africa for improving NCDs care in Africa? What do you think about the next move, the next urgent move?
Thank you. So I think the first thing is we need to give power to the people. The healthcare system cannot be the sole decision maker and implementer and management. Every single thing can fall under the healthcare system. So we need to figure out a way where the individuals get some level of information that allows them to take control of their health and be engaging enough so that even when they go to a hospital or to a facility to seek care, they know where to start from, because they're not in the dark. They're informed about what's happening, what are the trends, and because this is what leads to better decision making, which is the whole point of preventative care. If they have access to information, their everyday decisions are going to be different. And the results, the burden to themselves and to the healthcare system will be reduced, very much so. So for me, that's my biggest focus, and that's what my work focuses on. Give power to the people, and power is access to information. And then they'll make better choices with the hopes that they will make better choices. Thank you.
Thank you, please. From your experience, Dr. Mike, some African countries, they integrated NCDs care into their primary health care system, right? So please share with us the lesson learned from those countries so that others can try to learn from there and do this successfully.
Well, yeah, I think I'll just put up about three lists, right, or three items. And the first one again is also, I think we, just like we've stated in the gaps, is that we need to appreciate the fact that we don't have enough health workers, right, in Africa. I mean, we need to really agree with that. And with that, we know that our lifeline, of course, is the PHC. So, you know, one ways that have been, you know, tested is what I call the decentralized model of care. You know, and what this involves is the fact that some of these NCD care are decentralized to the primary health care, you know, and that means that you're talking about where you have, of course, you have community health workers, you have some of your nurses there, probably you might have a doctor there. So you are doing two things at that level. For those that have implemented this, is that you are decentralizing it to that level, right? And it's not just about decentralizing, it's also that there is simplification of protocol, right, to be able to manage, you know, and to be able to understand that the referral system, because this is the problem we have in Africa. You know, we've not been able to have this connect, you know, in terms of who is the gatekeeper and where should be the next level for referral. So yeah, for those that have implemented, they've been able to decentralize. You know, if you look at what is done in South Africa, you know, and some other countries, they've been able to decentralize to PHC, and also they've been also able to have a simplified protocol. The last one again is about task shifting. You know, task shifting is just an idea where you say, we don't have enough health workers. Can we train some other people that can do what I call, in a way, in the era of AI, we call it automated, or you call it routine task, right? It doesn't involve a lot of thinking. You know, it just, you know, maybe there is a framework, a simple algorithm that say, oh, when this kind of patient comes in, give this number of drugs. If you see this, let the person go to the next level. Yeah, those are kind of task shifting. And this may not necessarily involve a nurse. It probably involve a community health workers. And this will help to bridge, of course, the gap in health in the health force that we're currently challenging. So if we were able to implement this in PHC, of course, it will increase the access, to care that we're currently having in Africa.
Thank you, Dr. Mike. As from discussion, we have seen that the use of technology in NCDs management, right? So now we identified the use of technology and the barrier which I found in Africa. I want to ask Dr. Funmilola, what do you think should be the next move from African country in terms of NCDs management and technology at the same time?
Yeah, thank you so much. I think NCD management can really leverage on the use of technology in this part of the world. And I say this knowing that there will be certain barriers, but it's something that we can actually find a way around it. I could remember earlier on, Peace talked about the fact that we can find someone in a community or in a household that has a digital phone or something that can be used to leverage on so many things. So yeah, we can use technology because we can make them affordable. And remember that when we talk about technology, it's not only about internet and computer, even something as small as a radio, which if I use Nigeria as an example, almost all households in Nigeria has a radio. So you might be able to pass educational information using just the conventional radio to reach as many people as possible. That is affordable, that is accessible, that is everywhere. You're not likely going to leave any household untouched if you go that basic. But there are other technological advancements too that can be used, that can be centralized to different community, and this can help in improving what it is about the non-communicable disease. We've all alluded today that the role of education cannot be overemphasized. When you educate people, when they know why they are at risk, they are likely going to comply with whatever screening modality that you have recommended. And again, when you have this kind of bulk announcements going to people every time, they will know. Another thing is that almost everybody has a phone. Now, there's likely, I'm not sure there are many households where you won't find one person that have a phone. So you can use all our outlets where we make calls. There can be some bulk SMS in people's local languages, which can be used to assess them, and they can use to find information about them. I'm aware now that even in government Nigeria now, sometimes what you have to do, especially if I have to follow a patient or after a surgical procedure, we can actually set up a call to say, oh, do you have this? Do you have this? If you have this, come back to the hospital. If you don't have this, you can come back at a later date. And I think that's just one of the simplest ways that we can leverage on that. What are the barriers to this? We know that majority of rural areas still don't have adequate internet services. So for some bigger things that require internet services, that might be slightly difficult to implement, and that scaling might have to do with those kind of infrastructures that the government have to provide. But like I said, if we think about what the fintech people are doing across, I've been to rural areas in Nigeria where you can still use some of these fintech solutions. So I think if we really look inward, there might be a way that health solutions too can go through whatever has happened in the fintech space. And I think we can modify things towards that environment. And other scaling up would be the need for things like electricity, which is very essential when we talk about technology and reaching hard to reach areas. And this is where government comes into play in providing the basic infrastructures that will help us to scale digital health and to improve the digital health solution. So I think if we all are committed to making a difference from my own clinic, if I'm committed to making a difference from different non-governmental organization and at the government level and private level, I'm sure we are going to make a difference in the use of digital health and scaling up the non-communicable disease in Nigeria and in Africa as a whole. Thank you.
Thank you very much, Doctor. And thank you everyone who contributed to this discussion. We can't forget that you highlighted that in Africa we still have gap in the information of NCDs. we can't forget that you shared your insight on the investment of African countries to NCDs program, and we still have gap in centralizing the services and information of NCDs in Africa. Regarding the global innovation, we discussed how the tool should be designed and developed to local and community based. Then access to the information is one of the global innovation should be implemented in Africa, where we have monitoring, is getting feedback on the information, access to care easy from the technology integration to NCDs management in Africa. Here we have get insight on the giving power and full right to the community in terms of adapting their idea, their integration in NCDs management, and you have identified stigma as one of the issue of cultural factor in Africa. We have seen the program intervention, how should be collaborated with different stakeholders, including community, public, private, and other stakeholders to improve NCDs in Africa. Let's move to the few questions from the audience, then ask panelists to address the questions. I think the first question we have now is for Dr. Funmilola. It's in chat box saying, if implementation is one of the main barriers, despite having good policies in place, what practical steps or partnership do you think would make policy execution more effective on the ground?
Yeah, thank you. I think one of the things we need to do is actually to have a set out goals on how to monitor implementations. It's not enough that we make policies. It's important that we make sure that these policies reach the exact place we want it to go. And we know that when we are implementing new programs, we all want to do some monitoring, you want to do some evaluation, you want to have a targeted outcome. So I think that's what we need to do for all policies. So if we make policies that all under 5 children should have this immunization done, it's not enough that we just write that in wherever our headquarters is, like in Nigeria, in Abuja. It's important that there are people on the field that are monitoring all under 5 children. How are they getting this immunization? Are they getting it correctly? How many parents present their children for immunization? How many do not? And those that do not, why are they not presenting? Those that are presenting, why are they presenting? So that we'll know what are the practical steps that is really limiting some of our policies. Could it be because the policies are really not achievable? It's possible that we make policies because I think I have some knowledge about it and I really did not get feedback from the community, the people that are going to be taking back these policies. So I think those are the things. The major problem is that nobody really monitors some of these things. We make beautiful policies, but we need to put things in place, mechanisms in place that will help us to monitor whatever we had put in place. So I think it's more of execution, monitoring, and evaluating whatever policies that have been stated. That's one of the problems, and that might be a practical steps to help us.
Thank you very much for a great response. Hope Agedo you get a clear response. Another question from the same participant to Peace. Say, how can you ensure the local knowledge and lived experiences are integrated into the design of the NCDs intervention? And so solutions are not just imported, but truly adapted to African contexts. Over to you, please.
Thank you. So I think I've talked about this briefly earlier. And first, there is creating platforms for those people to voice their lived experiences, because all of us should learn from that. So in some cases, the platforms exist. An example is the NCD Champions, I think by WHO, where they have different community representatives who are living with NCDs, and then they act as the voices of those people in last mile communities. So that's one example of what can be done. But sadly, now we mostly focus on the people who are already living with these diseases. For people who are struggling to change their behavior, to follow all the preventative measurements or navigate the different risk factors. And I'll connect this to the last question in the chat. In the chat, it was directed to Dr. Mike. Apologies for stealing your spotlight, but he was asking about even the people who are educated and are aware about the risk factors, they still fail to to adopt the preventative strategies. And that's true. Even the doctors themselves, who every single day their work is teaching people about NCDs risk factors, they go back and fall into the trap of the risk factors they've been talking about the whole day. So why is that? And I'll talk about one thing, is the lack of motivation. Most of the decisions you need to make to prevent yourself from developing an NCD, they're very tedious, but on the other hand, it takes forever for you to see any progress. A simple example is how long does it take for someone to develop six packs? No one says you should get six packs, but anything, if you're eating right, if you're exercising, it's not like I'll wake up tomorrow and see the result. I might feel different, but it will take time for me to see what I've been working so hard for. And that kind of takes away the motivation. So that's why earlier I mentioned two things that we've seen that really help with the motivation. One of them is the community aspect. This is a very lonely and hard journey, and it only helps if you're doing it with someone else or with your own community. It can be a community of friends, it can be a community of colleagues, it can be your family. It depends, whatever you're comfortable with. In Rwanda, we have Car-Free Day, which is an activity that happens every Sunday, where every single person who wants to attend, there is a whole run around Kigali. People are comfortable with walking, do the walking, and then there is different exercises after the run. And some people who have never worked out in their whole lives show up just because they know they'll spot some of their friends. So now it has turned into a social event. If we failed to see each other during the week, it's like, are you going to Car-Free Day? If you're going, I'm coming. I'll do 5K steps while gossiping that I've walked. So that community takes away that, it brings in the motivation where it's not a lonely journey, but I have people who I'm doing this with. And the other one is when we're screening in the community, some people used to ask, oh, you're screening me, what am I going to get? And that's a sad reality. You're helping someone know their status, but they feel like you owe them something. But it's okay. If they need some rewards in any form or shape, that's possible. And that's what we've been trying to do with Lifesten. So we have partners on board who are willing to, most of the businesses we know in the health and wellness industry, they usually have discounts. But people still don't use their services. So for us, we're like, if it's a reward you want, we'll give you a reward. But what type of rewards are we giving? Sometimes it's one of the partners we have on board, they're called the free farmers. Depending on how you've been tracking, how you've been taking care of yourself, they send you vegetable baskets by the end of the week. So we know for the next week, you have to eat those vegetables because that's what you have and you got them for free. So the results also, we point you into the direction of the health and wellness initiatives you should be taking in the first place to prevent yourself from acquiring NCDs. So I believe the motivation which can come in from either the community or or gamification, rewards, attaching some type of reward to the effort someone has put into navigating these risk factors is also important. Thank you.
Thank you, Peace. I think some information provided is answering this question from Sharif, but let me check and see if you can add something. Said, I'm wondering how can a multidisciplinary team effectively collaborate to implement early detection and prevention strategy for NCDs? And what practical measures can be taken at the primary care level to ensure timely intervention? I think you covered many of this question, but if you have another thing to add, please go ahead.
I think that's for Mike. Maybe if you can check that.
I said because I have. Okay, but
Sorry?
fine. Go ahead.
It's okay. Yeah. Sorry. I mean, just like you said, Peace answered most of them. Just to really pick it up from where she stopped, especially the last question, right? Quite an interesting one. And I think I love the analogy that even health workers don't even follow through, right? But again, I think it all also boils down to, how do we communicate to the patient, right? And I've seen this, I've seen where you tell people that try to eat something, and what you are prescribing is not something that is indigenous, that is locally available. Definitely, nobody will follow through. It's quite funny that in Africa we talk about apple all the time, but it's not like we grow apple in Africa. So what should we tell them? We should tell them something they can get. And I think that is where the challenge is. You have to communicate in a way that they get you, and those things are locally available, right? I think that is, for me, that's one point I'll add to that. Now, talking about how do we create kind of a surveillance system at PHC level, I think the first thing, looking at multidisciplinary is also, I think the first thing is to look at the capacity. I don't know if all of us will look at the WHO PHC package. I don't know if that's been reversed, but NCD is not there, right? So first, that means that the PHC level is mainly set up for mainly infectious diseases, which of course. So first is to look at what the package is, and also to look at the capacity, right? For example, if you have a health worker at PHC level that takes a BP of 150, let's say over 100, does she know what to do next? Those kind of simple understanding. Or do we even have enough equipment to be able to test for diabetics, for instance? Or so those are, for me, those are the baseline that we need to put in place first at that level before we can say, oh, there is a kind of surveillance. So first is the capacity, equipment. Then, of course, as I always say, is also the referral pathway. I think for me, if these are in place, I think we'll be able to achieve the kind of a good screening process and a referral process also. Yeah.
Thank you, Dr. Mike. I think on the last question, I can make comment for everyone who is interested to respond. I'm asking to answer as practitioners in NCDs in Africa, what's your hope in the innovation and technology in Africa for NCDs? Your hope.
Okay, I think I can go from here. I hope that innovation will help us to scale better, to reach people better in the language that they understand. That is, in where they really understand what we are saying. That's the kind of innovation I think we should be aiming for. I saw one app that was designed by Nigerian women on breast cancer, and this app had so many Nigerian languages on it. I feel that's a very good innovation to educate people. So I'm looking forward to seeing health-related innovations on non-communicable disease that will be in a language that people understand, that will be speaking to our major problems in Africa, like knowing that internet might not be accessible. It should be something that can be used whether there is internet or not, and something that has a very good feedback mechanism in which people can reach out to via any other means to the people and to the healthcare professionals, and they'll be able to get a real-time advice. Because I think sometimes, because people can't get advice on time, they make decisions based on all other information that is available to them. Because if you had met people that came very late in advanced cases and you ask them, where have you been on this while? They have been to so many places, just that they have never been to the right place to get information. So that's my hope. I hope we'll get health innovations that will be able to reach people at the core and when it is needed. Thank you.
Thank you. From anyone,
Okay, I can just go quickly. Yeah, so for me, I think I totally agree. Yeah, so you see, one of the concepts that we try to promote in Health Innovate Hub is the concept of frugal innovation, right? So we're talking about innovation that is adaptable, innovation that is homemade, innovation that can also face the terrain. If you look at Africa, of course, we have a lot of challenges. Electricity is one. If you talk about telemedicine, for me, I think the future is about creating innovation that is homegrown as much as possible, and that can be used by the community. But again, I also want to say, sometimes when we discuss innovation, I'm a big fan of technology, and I believe that technology is the next thing for healthcare in Africa. But again, I feel that also innovation, especially as needed in Africa, is beyond just complex technology also. I feel that there are low-hanging fruit that we can quickly pick up. And that's why, when it comes to NCD, I think first is what to decentralize as much as possible at the primary healthcare level, and also to see how much of task shifting we can do. For me, I think this will, in the short to medium term, will be able to cater for the need that we are looking at currently.
Okay, Dr. Mike.
If I may add one thing, I hope we are as aggressive as we were in the early 2000s when it comes to HIV. I know for sure all of us will remember a song or a quote or anything from those times. There was a lot of funding, a lot of efforts to share information and for people to get screened. And we've seen how that drastically changed the trajectory of HIV/AIDS. And I believe if we're able to take NCDs as that serious, or we approach them that aggressively now, we'll be able to avoid one of the biggest public health outbreaks that is about to come up. So I hope our systems take it seriously, the population takes it as serious as it is, and we're able to take action without even necessarily waiting for this to get worse than it is.
Thank you, everyone. Thank you, expert, for sharing your insight and letting Africa know how local solutions should be integrated in NCDs management, and how innovation is now important in our NCDs healthcare system. Thank you, everyone. Thank you, participants. Hope you enjoyed the discussion, and see you in our next year webinar.
Thank you so much.
Thank you.